So hello, everybody, and we want to thank you so much for joining us this morning with the Scleroderma Foundation of California's virtual talk with our special guest, Dr. Furst, who's going to provide an overview on understanding heart-related symptoms in scleroderma and what to look for. Excuse my voice, I've been sick, and this is the best we can do with my raspiness. We are very thrilled to bring these educational forums to you in your own living rooms and hear from experts like Dr. Furst in the scleroderma world. So I'd also like to personally thank Dr. Furst for taking time out of his busy schedule, because he's one of the busiest people I've ever met. And he's joining us on a Saturday. They actually lost power at their house and drove down to UCLA so he can be here with us. So we greatly appreciate your time today. And this is an important and helpful presentation to the scleroderma communities near and far. And that helps all of our warriors put on what you keep hearing me say, the scleroderma suit of armor. And this is so you can gain your knowledge, make informed decisions related to your care, and hold your healthcare team to a higher standard, because oftentimes many of you are unable to see scleroderma specialists through your network. Before we go any further, I'm going to ask, I'd like to introduce our Executive Director of the Scleroderma Foundation of California, Andrew Emmett. He's going to say a few things, and then I'm going to go over a couple of housekeeping items, and then we'll introduce Dr. Furst and start the talk. Andrew?
Thank you, Tina. Good morning, everybody, and welcome to, if you're in Southern California, very cool and wet Saturday. So what a perfect place to be here and watching our session this morning. And I want to share some great news. After 3 years, it's back. We are finally going to do our gala. Our Key to a Cure 22nd gala is going to be Saturday, April 29th. Tickets go on sale Monday, so they'll be receiving an email on Monday, and ticket sales will be open, and you can learn about our honorees. The event Saturday, April 29th at the Marina Del Rey Marriott. So we hope you join us there. It's going to be a great welcome back after 3 years of not being able to have this event. I want to thank Tina for putting together today, and I want to thank Dr. Furst for being available and going all the way to UCLA after the weather we've had here yesterday. And I heard most of it last night. It was pretty severe. And some of you may be getting warm weather, some of you cold, but wherever you are, welcome. And thank you for joining us here today.
Thank you, Andrew. I want to remind everybody that the Scleroderma Foundation of California does not endorse any specific treatments, drugs, or research trials. Because scleroderma affects all patients differently, treatment approaches that may be appropriate for some patients may be less suitable for other patients. Any treatment decision should be based on knowledgeable discussions between patients and their clinicians. After Dr. Furst finishes his presentation in its entirety, I'll open the floor to questions from our audience and read them aloud to Dr. Furst in the order that they were received. I did receive a couple of emails, and I will also go over that with Dr. Furst. Please remember to wait until he finishes to type in your question, because often he will answer your question during his talk. And we included a survey at the end of the presentation, and we hope that you'll take the time to provide your personal and important feedback. Okay, and now it's time to introduce Dr. Furst. Dr. Furst was the first Carl Pearson Professor of Medicine at the University of California, Los Angeles Medical Center. Dr. Furst received his MD from Johns Hopkins University and 2 fellowships, Rheumatology and Clinical Pharmacology. Dr. Furst has been on a number of national committees concerned with rheumatic therapies. He recently was co-leader of the ACR recommendations, that's the American College of Rheumatology, for the use of non-biologic and biologic therapies in rheumatoid arthritis, and is a master of the ACR. Dr. Furst has published more than 650 articles, 15 books, including more than 220 research articles. Dr. Furst's area of research interests include the clinical pharmacology and anti-rheumatic drugs and biologics, and the pathophysiology and treatment of systemic sclerosis. Dr. Furst has provided numerous educational talks and participated in many scleroderma events, bringing awareness to the disease, raising money for a cure, and participating in advocacy near and far for many organizations supporting scleroderma all around the world, and his efforts are greatly appreciated by all impacted by the disease. Please join me in welcoming Dr. Furst.
Good day, everybody. And that my mother would have loved to hear that introduction. I appreciate it very much.
Thank you.
Can we have the first slide?
Yes, so give me 1 second. Andrew and I are going to go off camera. I'm going to share my screen and I'm going to highlight you. So give me 1 moment.
Okay. And this talk today is a difficult talk in some ways because we talk about death and dying to some degree. I want you to remember that as we talk about that actually death from heart disease in scleroderma is very rare, accounting for about 1.3% of the deaths. So even though I talk about it a lot, it is aimed at getting you to understand it and to be able to know what we can do about it. So I'm going to talk about the heart in scleroderma. Next slide, please. I have some disclosures. I work with a number of companies in order to be able to do my research. Next slide, please. What I'm going to do is I'm going to talk about these 5 areas. First, something about the statistics and how often it happens and so on in terms of heart involvement. Then, in order to understand it better, I thought it would be useful for you to understand what causes the heart disease. Of course, we need to know, and you need to know, how to get this diagnosed, and then the sorts of things that predict heart involvement. And then lastly, of course, and very importantly, what to do in terms of treating heart disease in scleroderma. Next slide, please. First, something about the background statistics. Next slide, please. When you think about scleroderma and the possibility of dying from scleroderma, and you think about heart disease, it comes down to that over about 3 years, about 9% of people may die from scleroderma. But just so you understand, the mortality has been improving very, very much. And now the 10-year mortality from scleroderma is about 14%. Among those, only 1.2% are due to cardiovascular events. And when you think about it here, you see 2 studies. The top study points out that the 3rd most common cause of death is heart disease. And it is approximately equivalent to cancer deaths in patients with scleroderma. And in the bottom slide, you see very clearly that the 4th most common cause is cardiovascular disease. So about the 3rd or 4th most common cause of problems of that sort in scleroderma. Next slide. If you think about what goes on, this looks at survival over 10 years. And if a person has neither lung nor heart nor kidney disease, you see the top line where the arrow is, and you see that mortality is about 14%, survival about 87%. If there's lung involvement, then survival drops significantly. And if there's heart involvement, it is about the same. Kidney involvement results in much more severe problems. And of course, if you have all 3, that's real problems. But the heart here and lung are the things that account for a fair amount of the problems in patients who have scleroderma. Next slide, please. And the risk of cardiovascular disease compared to the normal population is what you see on the right. The dotted line is the normal population, and you can see that there's an increased risk of dying from cardiovascular disease in scleroderma, all the way along from diagnosis onward. To get a feel for this, if you think about death from MI, it occurs in about 3 per 1,000 patient years in the general population, and about 4 per 1,000 patient years in patients with scleroderma. If you look at strokes, it goes from 1 to 5, so that there is an increased risk of cardiovascular, vascular deaths in scleroderma. Next slide, please. If you look at it carefully, you see that only about 15% of patients with cardiovascular problems have symptoms from it. Most of it is asymptomatic and doesn't seem to cause any significant problems. However, if you look at very, very sensitive ways of measuring it, looking at blood flow, you can see that there's abnormal blood flow in 60% of patients who have scleroderma to the heart, and that some abnormality in the heart occurs in 3/4 of patients. That does not mean that necessarily that's always a poor prognosis. It does not mean that there are going to be symptoms. It just means, like, for example, in the skin, you can have involvement, but that does not mean necessarily things are going to be terrible, or joint involvement, or lung involvement for that matter. But abnormalities abound. Next slide, please. Well, let's talk about how those abnormalities occur, the pathogenesis of heart disease in scleroderma. Next slide. You can see here the outline of how scleroderma occurs. And on the right, you see that there's immune activation. But in scleroderma heart disease, the main problem is vascular disease, and that affects the immune activation, both of which result in collagen, which is what affects the heart in scleroderma. Next slide. So the blood vessels are the main source of difficulties. And what happens is there's a substance called nitric oxide, same stuff that people use as an anesthetic. And nitric oxide causes vasodilation, opening up of the blood vessels. And in scleroderma, secondary to inflammation, that nitric oxide gets broken down more frequently than normal. And not only that, but through other mechanisms having to do, for example, with cholesterol, there's decreased synthesis of this nitric oxide. So there's increased breakdown and decreased synthesis, overall resulting in vasoconstriction, blood vessels clamping down. What happens in part is that the endothelium, that's the inner lining of the blood vessels, is injured by inflammation coming from the immune system. And all three of those things end up in what you see on the right. First, increased vasoconstriction. You can see the blood vessels are smaller. And second, buildup of inflammatory substances like cholesterol and damage to the blood vessel. Next slide. What does that result in? This is a very fancy technique called laser speckle contrast imaging. It's an infrared way of looking at blood flow. And you can see here, this is a very small study, only 15 patients, but they had very early disease, 1.3 years, and they had some controls, which are matched. And you can see that what they do here is, in this study, they blow up a blood pressure cuff above blood pressure, above systolic blood pressure, and they hold it there. So there's decreased blood flow to the arm. And then they let that go, and they see how quickly the blood flow returns. And that's called reperfusion. And you can see in scleroderma, because there's damage to those blood vessels, there's less return of blood flow to the arm and through the blood vessels in scleroderma than in normals. Next slide. I would need to stop just for a second and give you some definitions. You can see this is the heart, and on the right there, you see that pink line between the dark which is the blood, and the light purple, which is the muscle, there's something called the endocardium. That's the tissue between the blood vessel and the rest of the muscle. And just under that endocardium is something called the subendocardium. So that's tissue that's between those cells that are between the blood and the tissue. And just underneath that is the subendocardium. And that's important, and I'll show you why. Next slide. This looked at a few patients with diffuse and with limited scleroderma, and they did something called a gadolinium scan. This is a scan which looks at the inflammation and blood flow in the tissue. And they look at an MRI and look to see if after the first flushing of the gadolinium through the blood and through the body, what's left behind. That's called late enhancement. And that occurs with fibrosis. So when you see late enhancement of gadolinium, that is the fibrosis that occurs there. And what you see is a couple of things. First of all, you see on the right that there's subendocardial. Remember, I showed you those tissues. Perfusion defects, that's the smallest blood vessels in the heart, are not working very well in about 80% of patients. It's not the coronary arteries, not the usual stuff that causes MI. When they looked at the coronaries in these patients, 90% of them had normal coronaries, and a few percent had the usual arteriosclerosis. And it was more common to have that fibrosis associated with a subendocardial defect in patients with diffuse disease than in limited disease. And you can see that there. So fibrosis occurs in nearly half of patients with scleroderma, but more commonly in those with diffuse than limited disease. And it's not coronary abnormalities, and it's in the subendocardium. Next slide, please. This is another way of looking at it. This shows you some of the small vessel abnormalities. And you see on the left, this is late enhancement of gadolinium, and that white stuff there is the fibrosis. Next to it on the left is the blood in the ventricle, and on the right, the blood in the atrium. And when you look at the other side there, where you look at the subendocardium, you see that what lights up is the subendocardial tissue, which isn't lit up as much as you'd like it to be. So you see both the fibrosis and the subendocardial damage that occurs in the heart disease in scleroderma. The causes of the heart disease being that subendocardial tiny vessel abnormality resulting in the fibrosis or scarring. Next slide, please. So I think we just skipped a slide. Can you go back one? Yeah. So that's what I just showed you. Now the next slide, which actually just reiterates what we said, that there's vascular damage in the microvascular area and there's fibrosis. Next slide, please. So the cause of heart disease is tiny vessel abnormalities in the subendocardium and other places, but mostly in the subendocardium, resulting in scarring in the lungs or fibrosis. So what kind of symptoms result from that? Next slide, please. I'm going to break this up into these four areas: the myocardium, or the main tissue, muscle tissue, the valves, the coronary circulation, the electrical system, which causes the ordered contractions, and the pericardium, the area around the heart muscle. Notice that the pulmonary circulation, which is right next to it, and of course depends on the heart, is not something we're going to talk about, because that's a totally separate lecture on pulmonary arterial hypertension. Next slide. So one of the main symptoms? And this looked about at a survey, and these were patients who were moderately disabled, mostly women. The main symptom was fatigue. Now, we all know that fatigue is very nonspecific, right? Darn near anything can do it. For example, inflammation in the muscles, ongoing long-term pain, depression, lung disease, GI disease. So it's very nonspecific, but it's important. In scleroderma, very frequently, the very first sign of the scleroderma is fatigue. And in heart disease, fatigue is also one of the main first early symptoms, non-specific, but definite. Next slide. So if you look about the irregular rhythms or the pericardium or the myocardium or the valves, what are the main symptoms? Well, you can see looking down that list that fatigue is the main symptom in 3 out of the 4 cases. And when there are irregular rhythms, you feel it as irregular rhythms, palpitations. And that, if the if the heart isn't pumping out normally, makes people feel faint or dizzy, or they can even fall. And if the heart is involved, then it isn't as efficient. And so you can get fluid called edema in the legs, mostly in other areas, and get short of breath. If the valves are involved, many of these occur. But I need to point out that the valves are not a principal area where the heart is involved in scleroderma. It's usually secondary. Mostly it's the first 3. So fatigue, palpitations, edema, shortness of breath, dizziness, all are symptoms that occur commonly in heart disease in scleroderma. And remember again that these are non-specific. They don't point to the heart, but they do point to something going wrong. And frequently it's because the heart isn't functioning efficiently. Next slide. There's something that occurs in scleroderma that's a little unusual, and that's basically Raynaud's phenomenon of the heart. If you look at the bottom row where it says E, what you see on the left is that area where you see just faintly the heart tissue, and then when there is cold, you can see that that area becomes less. You see it's very dark, and then it becomes lighter, and that's lighter because there's less blood flow to the area. And if you look at F, you can see that the subendothelial area is white or affected. And it's after there's cold involvement that occurs. Next slide. This is a little clearer picture of it. On the right, you see A and B, and you see where the arrow is, the white little dots, that's blood flow. And that's blood flow at the apex or pointy part of the heart. When there's Raynaud's of the fingers, there's Raynaud's of the heart. And you can see that where there was blood flow before, those white dots, there's less blood flow now. And when that's looked at very carefully, and you look at it in terms of what's called ejection fraction, that's basically the efficiency of the heart. You can see if a patient has Raynaud's, the efficiency of the heart goes down a little, from 62 to 55%, and that's statistical. In the control group, where there was no Raynaud's, under the same stimuli of cold, there was no change in the ejection fraction. And if you look at what's called the LVEDI, it gets awful alphabet soup kind of thing. It basically the LVEDI looks at diastolic dysfunction, where the heart is not working very efficiently during the time when it's quote unquote resting, diastolic. And you see here that there's more diastolic dysfunction after Raynaud's compared to controls where there's no increase in diastolic dysfunction. So this shows, one, a picture of Raynaud's of the heart, and two, that when there's Raynaud's, the heart just isn't functioning as well. Next slide. So when you think about signs and symptoms, the principal one is fatigue, and then signs of the heart not working as well: shortness of breath, accumulation of fluid called edema, irregular heartbeats, all signs that the heart might not be as efficient as it should. And then Raynaud's of the heart, which sometimes actually feels like what people call angina, but it's called vasospastic angina in this case. Next slide. So how do you diagnose this? Well, there are a number of ways, and we're going to go through some of them. There's the EKG and the echo. There's something very important called the cardiac MRI. There's this very specialized way of looking at blood flow called laser speckle contrast. There's a blood test, and then there's more exact but invasive things like the right heart cath and the tiny little biopsy of the tissue. Next slide. So what we're going to do, we're going to look on the right. You can see on the right there, we're going to talk about arrhythmias. We're going to talk about the result of fluid around the heart, pericardial disease. We're going to talk about myocardial disease, disease of the tissue itself, of the muscle. We're not going to talk about the valves. We're not going to talk about the lungs. That's a whole different area. Next slide. When there is cardiac involvement, besides the fatigue, there's the edema, there's something called PND, which is feeling very short of breath when you wake up and needing to sit up to catch your breath. Any heart disease will do that. But when it's scleroderma heart disease, it'll do that too. But there's more shortness of breath. The important thing is that when that occurs, one has to be sure it's not something else. So you have to rule out viral disease, toxins that may be in the environment, alcoholic disease, all sorts of other things. Next slide. So let's talk first about the arrhythmias, the irregular heart rhythms. Next slide. What happens is that the tissue that makes the heart pump regularly, called the conducting system, exists in the heart up near the atria, and then right in between the ventricles, and then tissue moves down, specialized tissue that makes the muscle contract in a regular way to enable the heart to pump out blood. And in scleroderma, what happens is in those conducting tissues, there's fibrosis. That fibrosis coming from those tiny microvascular abnormalities. And in this study of 10 patients, this was an autopsy study, in nearly half the patients, there was fibrosis in the sinus node up in the atria. And there was fibrosis in half of the tissue where the ventricular contractions start, and then a little bit further on down in the right bundle and the left bundle of tissues that are specialized to help the heart contract. So fibrosis in those tissues causes arrhythmias. Next slide. And these are what these arrhythmias can look like. Here are normal rhythms. Here are what are called PVCs. And here are a set of PVCs that come one right after the other, called ventricular tachycardia. And when this happens, the heart becomes very inefficient and it loses its own oxygen supply as well. So one of the things you can pick up on an EKG is these kind of arrhythmias. Next slide. And when you look at a group of patients who've had very severe disease and died, it was arrhythmias that caused the death in 40% of them, and left heart fibrosis in another 24%. Then other odds and ends. Next slide. So let's look at the next slide. And in doing an EKG in patients with scleroderma, some sort of EKG abnormalities occur in 60 to 70% of patients. Next slide. Most of them are what are called non-specific STT waves. They say there's something going on, but they have no clinical consequence. They also occur very frequently in patients without scleroderma. Next slide. Arrhythmias, such as you saw there, that those are PVCs. There are also supraventricular arrhythmias. And if there are a lot of them and they come together, they require treatment. Next slide. Arrhythmias occur quite frequently, but when they occur and a lot of them are together, they can be dangerous. All of us can feel an irregular pulse every now and then, sort of ka-thump. Usually just after you lie down at night, but that can happen to anyone. And 5 of those PVCs are normal, but when there are many of them, it can be dangerous. Next slide. So arrhythmias can cause problems. What about pericardial disease? Next slide. In an autopsy study, pericarditis occurred in 1/3 of the patients. Pericarditis is inflammation of the lining of the tissue around the heart, the pericardium. Next slide. We can pick that up with an echocardiogram. This is a diagram of what that is, and many of you have had this. Next slide. What happens is sound waves are bounced off the tissues, and the different densities of the tissues result in different speed of the sound waves going on to where they're recorded. So you can get a picture of the heart this way. It's very safe. Next slide. And you can see up at the top a picture of an echocardiogram of the heart. Might be able to see here the valve. Here's the myocardium. Here's the septum between the ventricles. Here are the ventricles and the atria. And there's something called tissue Doppler, which gives you more pretty pictures. And you can see here, here's the valve, more easy to see, the septum and the myocardial tissue. And the echo can give some pretty good pictures of specific things. One, it can give a good picture of overall heart efficiency called the ejection fraction, but it cannot tell fibrosis or scarring per se. It often is used to measure pulmonary arterial hypertension, but it isn't that accurate for that either. It's sometimes used to make the full diagnosis of PAH, pulmonary arterial hypertension. And under certain circumstances, it's really pretty good, but it can be wrong. So some people think it's more accurate than it actually is. But the echocardiogram can give you this picture of the heart that you see. Next slide. Pericardial disease causes symptoms in only 10% of patients, and acute symptoms like chest pain that can feel like a heart attack in 2%. And there is fluid around the heart in many patients. A small amount of fluid, or a moderate amount, which does not in any way constrict the heart, occurs in about 90% of patients. But 3/4 of them have no symptoms at all, and about 1/4 have some symptoms. More important symptoms in 10% and severe symptoms in 2%. Next slide. So pericardial disease occurs frequently, usually does not cause any real problems, but now and then can cause symptoms. Let's talk about myocardium, the heart muscle itself. Next slide. In a large study of 7,000 patients, they had echoes done. This is a USTAR database. We use that a lot, the European database. And what was found that about 5% had what would be called decreased pump function, left ventricular ejection fraction, less than 55%. So 5% had some significant decrease in the pump function. Next slide. The best way to figure that out is with a cardiac MRI. Next slide. This is what a cardiac MRI looks like. This is the muscle. This is the blood. And you see this little line here? That's the endocardium and the subendocardium. And there are two ways of measuring this in an MRI called T1 and T2. The T1 image, when it's bright like this, talks about fat. The T2 image, which you see here, looks about fat and fluid or inflammation. And when you take this from this, then you see how much of the heart is inflamed or swollen. So what you see here is basically edema or inflammation of the heart. Here again, this is the septum between the ventricles and the atria. These are the ventricles, these are the atria. Next slide. This gives us a pretty good picture of what's going on. You see over here, the tissue around the heart. This is the myocardium. And you can see here how much less bright it is, showing less perfusion of the heart. Next slide. This is a normal heart. This is the blood. This is the myocardium. This is an across picture, not a up and down picture. And what you see out here, I made a picture of it here for you, is the fibrosis or scarring. And here, on a different picture, you see the myocardial edema. The fibrosis does not go away. Like any scar, it can become smaller, but it does not go away. It's irreversible. But the edema is reversible. Next slide. So here you can see another way of looking at this. Remember I mentioned to you the late gadolinium enhancement? Well, what you see here is the late gadolinium enhancement in the tissue. This is the myocardium. Here's the blood. Here's the muscle. Here's the outside of the muscle. And you can see the late gadolinium enhancement or fibrosis in the heart. And here's another picture of it, showing clearly fibrosis in the heart. Next slide. And the MRI is very good at picking this up. This looked at 70 patients, most of whom had the usual picture, 50% were diffuse, and they used a standard MRI that measures in Tesla units. No, it's not the car, but 1.5 Tesla units, and they used gadolinium, okay? And all of these patients had a normal echo. But when they did the cardiac MRI, 50% of them had an abnormal MRI showing fibrosis. The other 50 did not. So you can see fibrosis or scarring in the heart even when an echo is completely normal. Remember what I said before, fibrosis per se does not indicate inflammation, does not necessarily indicate that there's going to be death. It just says, like any other part in scleroderma, that there is some scarring or fibrosis going on. Next slide. So the magnetic resonance, the magnetic resonance imaging, the MRI of the heart, tells us a lot about scarring and edema. And it really is the best measure of left ventricular function. However, the echocardiogram, which is much less expensive, much easier to do, also gives us a pretty good handle on right and left ventricular function. However, to get fibrosis, you need to do this late gadolinium enhancement. The problem, of course, is that it's gadolinium, and gadolinium is a foreign substance, and so it can cause side effects like anything that we put in our bodies. And the MRI is really quite expensive. The echo is expensive enough, it's about $500, but the MRI is anywhere between $1,100 and $1,500. Next slide. So, how else can we tell about the amount of blood vessels that are functioning in the heart? Well, we can look at what's called the coronary reserve, looking at this laser speckle contrast. This is this infrared way of looking at blood flow. And it can show us abnormalities in the very small vessels, the microcirculation. Next slide. And it comes back to this. Remember, we did this in the beginning, and it showed us that the microcirculation in patients with scleroderma is abnormal compared to the controls. Next slide. And when you look at it very carefully, what you see on the right upper corner there is that there's decreased myocardial blood flow in patients with scleroderma. Okay. When you compare that to large blood vessels, like, for example, the carotids or the aortic, the blood flow is normal. But in the heart, there's decreased blood flow, decreased coronary reserve. Next slide, please. There are other ways to examine the heart. Next slide. One way is a blood test. It's called an NT-proBNP, or a BNP sometimes, but the NT-proBNP, for various technical reasons, is better. And you can see that the NT-proBNP, which reflects damage to the muscle, is higher in scleroderma on the right upper corner. And that when you use the late gadolinium enhancement, i.e. more fibrosis, and therefore more damage to the heart, the BNP is higher than when it's normal. So the NT-proBNP is a rather non-specific, rather not sensitive, but very easy test that can be done to look at damage to the heart muscle. Next slide. Another thing that can be done is an endocardial biopsy. Sounds like terrible, doesn't it? But it's a tiny little piece of tissue. When doing a right heart cath, and you all know about right heart caths, they give us an idea of how the muscle is working, how the blood vessels are working. You can also do this biopsy, which takes a tiny piece of tissue from the inside portion of the heart. It's not dangerous. Next slide. You never say not dangerous, of course, but it's very rarely dangerous. This looks at the left ventricle of a patient that had scleroderma. And all that white area is the fibrosis. And you see in the middle here that it's right up against the endocardium and right here as well, so that you can get a biopsy and get an idea of the fibrosis. But you can also see one of the problems of the biopsy. So if you didn't happen to get it here or here and got it here, it might look pretty normal. Most of the time, based on other imaging, you can figure out where to do the biopsy. Next slide. And this looks at one of these biopsies. And what you see here is that this is a normal muscle tissue, and all of this is fibrosis, showing the fibrosis in the very inner layers by the endomyocardium and subendomyocardium of the heart. And below it are special stains. The pink are muscles, and the, I don't know what you want to call it, the other tissue is fibrosis. Next slide. This shows it up better. The upper is a normal myocardium. Here is the tissue that you saw before with normal muscle and some fibrosis, and here with a special stain that lights up the fibrosis. And if you look over here, you can do special stains which look at the type of cells there. What you see here are activated T cells. That's part of the immune system. And those lymphocytes, which are part of the immune system when activated, have a marker on the outside called CD3, and that marker lights up when they're there. And in this tissue, you see that there are all these activated T cells. Furthermore, there are activated macrophages, which you see here by a different kind of stain. So with a myocardial biopsy, you can see not only the normal tissue and the fibrosis, but the kind of cells that are causing the damage. And just to make it clear, here is normal tissues for this CD3, those activated T cells, and here it is in scleroderma, pointing out that the immune system also is active in the heart in scleroderma. Next slide. This looks at that conducting system. Here's the AV node, here's the left bundle and the right bundle, and you can see that in this particular patient, this was an autopsy specimen, there was fibrosis to a great deal of it, which must have resulted in a great deal of arrhythmia. Next slide. The blood vessels are also affected, and here you can see this is a blood vessel, and these cells are endothelial cells. They should be one layer thick, like over here, but you see how much they've duplicated, showing that the endothelium of the blood vessels that are feeding the heart are involved, the microcirculation of the heart being involved and causing the heart disease in scleroderma. Next slide. This looked at a systematic literature review that was done by Dr. Bruni and several of us, and it looked at 172 papers. And what they found, looking at those endomyocardial biopsies, was inflammation was very common, 80% of the time. Fibrosis was very common, 60% of the time. And that collagen and other vascular abnormalities and even death of cells can be seen. And in 30% of the time, the fibrosis affected the conducting system. So this is a rather common phenomenon, the inflammation and the fibrosis and the collagen and even the cellular death from endomyocardial biopsies. So even though they sound terrible, they are sometimes extraordinarily useful. Next slide, please. So how do you work up a patient who has potential heart disease? Well, first of all, you listen to the signs and the symptoms. Whoops. Can we make that large again? I messed that up. Well, we can work with it this way. These are the signs and symptoms. And then you look at the echo and the EKG, and you look at the blood test, right? And then with the EKG, you can do long-term echo EKGs called Holter monitors, so you can look at arrhythmias. And then you can do cardiac MRIs, and finally, you can do endomyocardial biopsies. So this is the full workup, but it starts with the signs and symptoms that patients tell us about when they come in. Next slide, please. Well, so we now know how to do it. What are the things that predict heart problems? Next slide, please. One of the things is that when you do an MRI, you get the signs of fibrosis. And when there's fibrosis in the heart, this is the heart muscle, there's fibrosis in the skeletal muscle, the normal muscle. So patients who have a lot of fibrosis in their regular muscles are more likely to have fibrosis in their heart muscle, with a correlation of 0.6, which is really pretty good. Next slide, please. And here they looked at 3,300 patients after nearly 20,000 person years of follow-up, where 1,000 deaths occurred. And what they found was that the predictors of those deaths were, first of all, this is the hazard ratio. So a hazard ratio of 1.6 says a 60% higher probability than the control population. And in this case, increasing age predicted survival or lack of survival in scleroderma patients. That's no surprise. The older a person is, the more likely they are to die. And men were more likely to have cardiac disease than women. And when they had more disease, that is kidney, heart, or lung disease, more severe disease, they had a higher probability of dying. And when their SCL70, the blood test associated with scleroderma, occurs in about 30% of patients, they also had a slightly higher probability of dying. Next slide, please. And what I did is I looked at all the studies looking at prediction of worse outcome in heart disease and scleroderma, and there were 5 of them. And all 5 said that higher age was associated with more heart disease. Of course, that makes sense, has nothing to do with scleroderma itself, but that men were more likely in 4 out of the 5, and that severe disease, muscle problems, heart problems, lung disease, kidney problems, more severe disease were more likely to be associated with heart disease, although varying percentages in varying of the tissues. But basically, age, being a male, and more severe disease predicted more likely heart disease. Next slide. And that's what this says. Being a male, being older, the lung in this case, but basically more severe disease predicts heart disease in scleroderma. Usually, blood tests are only mild predictors, but diffuse disease per se, if it reflects more severe disease, was. But having diffuse disease only was not. Males, older people, and more severe disease predicts cardiac disease. Next slide. Well, what about treatment? Let's talk about that for a bit. Next slide. Now, when it comes to treatment in the heart in scleroderma, there aren't many, there are very few actually well-done studies. Mostly it's case series where some cases are seen and seem to respond and they're put together, okay? There are some examining inflammation in the heart muscle, inflammatory, dilated inflammation of the heart, myocarditis, which can be used to help us. It's not scleroderma per se, but it's in the inflammation that is also found in the heart in scleroderma. Next slide. What you see here, one of the treatments that really makes a difference. Here are two patients, and you see up here, ventricular tachycardia. Remember we said when that happens, the heart becomes non-functional, right? And here another patient with the same thing. And what was done was an implantable cardiac defibrillator was put in. Next slide. And when that was done, it all became normal. So one treatment for the severe arrhythmias is putting in a cardiac defibrillator. That's a very common procedure. It's an invasive procedure. Of course, what they do is they put a little electrode right where the arrhythmia occurs, hook it up through a cord to a battery, and a sensor, and when one of these arrhythmias occurs, it gives a shock to the heart. You feel it as a little ting more than anything else, and it prevents you from having ventricular tachycardia. Next slide. One of the things that's used is steroids, and we all hate steroids, and we also hate high-dose steroids. And in this case, they use pretty high-dose steroids, but it is sometimes used for heart disease. You can see here the T2 image, see the inflammation? And when they gave corticosteroids, you see the inflammation went away. It was gone by 30 days and remained gone after 2 months. So that even though there aren't many studies, this is the kind of study that says that probably under certain circumstances, corticosteroids can be used to help myocardial disease. Next slide. Anti-inflammatories can also be used, and immunosuppressives. This is a study with methotrexate, and it looked at RA and a group of diseases like ankylosing spondylitis called seronegative arthritis, but it decreased strokes and MIs. And you see here some studies which indicated a decrease by about, what was it? I'm having trouble reading it. I think 37% or 36% when you used a strong anti-inflammatory immunosuppressive. This was in strokes, this was in heart attacks. And you can see that, or vice versa, but because I can't read it, but the one was 36%, one was 27%. In both cases, using a strong anti-inflammatory, you could get improvement in heart disease and prevention of strokes and heart attacks. Next slide, please. This looked at the inflammatory dilated myocarditis. This is the kind of thing that's the severe problem in scleroderma as well. And this was a double-blind trial looking at an immunosuppressive called azathioprine or Imuran plus prednisone versus a placebo, so a well-controlled trial in which they used very high-dose prednisone, about 60 milligrams a day, going down to no prednisone, but leaving azathioprine on the whole time. And these patients, when they started, had a very inefficient heart. Normal ejection fraction is 50% or more. In this case, 40%, anywhere between 23, 25% in general at baseline. And what you see here, here's the mean ejection fraction in the placebo group, and here's the mean ejection fraction in the treatment group. It's very clear that this treatment improved the efficiency of the heart, and it improved it in a very short period of time, as you see here in this slide. Now, by 2 years, this difference had gone away, but there was clearly a response early on. Part of the reason it had gone away was the numbers were very small at that time. So by 3 months, these two treatments together versus placebo improved heart function. What is this telling me? It's not specifically scleroderma, but it's saying to me that an immunosuppressive plus a strong anti-inflammatory, prednisone, can help the myocarditis that occurs in other diseases as well, but in scleroderma heart disease. Next slide. This looks at atorvastatin. You know, that's Lipitor. That's the drug we use for cholesterol. And what you see here in a small number of patients, okay, now this was an open study, and patients were on their regular other treatments in the background, but they were either given atorvastatin, Lipitor, or not, and followed. And here you look at the ejection fraction. Remember what that is. And you can see that using Lipitor, there was a clear improvement in efficiency of 7%. And in the control group, there was no change, 1%. So you can see here that atorvastatin helped inflammatory dilated myocarditis, the kind of severe heart disease that can occur in scleroderma. Next slide. And so what's taken from that goes beyond the studies, because I remember I said there really aren't very good studies. But it looks to many of us that if you use good anti-inflammatory meds, sometimes immunosuppressives, you can help the heart disease in scleroderma and other diseases. This isn't based on data. This is based on taking this little data that exists and extrapolating it to the best that we can do. So things like infliximab or etanercept or other TNF inhibitors or Actemra or even something called anakinra can probably help the myocarditis that occurs and can at least stabilize and perhaps improve the microvascular disease that is behind scleroderma heart disease. Next slide. This looks at a very small study in a group of scleroderma patients who had other kinds of myocarditis ruled out. That's why it's called virus negative myocarditis. And it was a very small number of patients, and they did endomyocardial biopsies, and echoes, and everything else. And what they used here was steroids in 33% of the patients, azathioprine in about 60% of the patients, an immunosuppressive, mycophenolate, MMF, you're all familiar with that, in 42% of the patients, and occasionally cyclophosphamide, which we don't use very much. What does this tell us? It's an uncontrolled study. It's a small study, but it's in scleroderma patients. And in those patients, most of whom did pretty well, the use of steroids and immunosuppressives seems to be a reasonable approach in this case. Next slide, please. So if you look back on this, and this is kind of what was put together by a group of folks who said, okay, this is what we think is the best way to go. If there's the heart disease of scleroderma, you can use steroids, you can use methotrexate or mycophenolate, you can use atorvastatin, Lipitor. If you have arrhythmias, there are lots of meds that use for arrhythmias that work. You can use a pacemaker or ICD, we talked about that, or you can do something called ablation, which isn't quite as well worked out for scleroderma, where they find the place from which the arrhythmia starts and they zap it so it kills the tissue right there. When there's coronary artery disease as well, remember about 7 to 10% of patients, you do everything that you do for coronary artery disease, right? Aspirin, statins like Lipitor, beta blockers, fluid pills, etc. And you can also use percutaneous methods to help the heart. So this is what's done for the heart. I'm going to go back because the cardiomyopathy, the heart disease, the basic heart disease is treated with immunosuppressives and anti-inflammatories, and the arrhythmias, which are such a cause of problems. Remember, 40% were a major cause of problems. We have good treatments for that, non-specific, but pretty good. Next slide, please. Able to get up the next slide? Tina, are you having problems? Ah, she did it. Good on you. So, in conclusion, the heart involvement is frequent in scleroderma. It's often asymptomatic, but in a small percentage of cases causes death. Early diagnosis, like early diagnosis in most things, can avoid progression in heart failure or cardiac failure. This is likely, not proven, but likely. There are medications, there are treatments for arrhythmias, there are these defibrillators that can be put in to help the treatment. The diagnosis is made by the EKGs, echoes, MRIs, other things such as myocardial biopsies occasionally can be used. And steroids and anti-inflammatories and immunosuppressives are being used. So there's less data supporting everything that we do to treat, but there are some data, and we have an increasing understanding of what's going on in the heart in scleroderma. Next slide, please. And I want to leave you with this. The first 5 days after the weekend are the hardest. Thank you for your attention. So let's see what kind of questions we've got. We have some.
Thank you, Dr. Furst.
Sure.
Okay, first question. I have fibrosis in my left ventricular due to scleroderma. I'm in advanced heart failure, and it has caused me to have pre and post capillary pulmonary hypertension. Would a medication like Actemra possibly help slow or stop future fibrosis? I'm currently on the maximum dose of beta blockers and what is this? Spironolactone? Am I saying that?
Spirolactone, yeah. Spironolactone, that's a diuretic. It's a good question. I don't want to go to an individual person, but the fact is that tocilizumab or Actemra seems to affect the inflammation and the therefore stop the fibrosis. Consequently, using a medicine like that or azathioprine or TNF blockers can hopefully prevent further progression. In some cases in scleroderma overall, it actually helps reverse things. But I think that if you have scleroderma and if you have severe disease, then you should be on one of those medications, or perhaps 2 or 3 at a time.
Thank you. I have a positive biopsy for endomyocardial fibrosis and a negative MRI with contrast. Should I repeat the biopsy?
So the question here is, how good is the biopsy at telling what's going on? When the biopsy is positive, that has great specificity. It really tells you that there is that there. The fact that your cardiac MRI is good is a wonderful sign. Remember what I said, that biopsies are subject to what we call sampling error. So you can get a little bit of fibrosis, but it may not be enough to even show up on a cardiac MRI. But it says that there is a little bit of scarring in your heart. But the cardiac MRI says that that scarring is really not functionally important. You don't need another biopsy, and you should go about your life and just be sure that nothing more happens. You're doing great. Next slide. Next person.
I've had scleroderma for the past 25 years. I had hypertrophic cardiomyopathy and had a septal myectomy in 2019. Last year, I was diagnosed with a stiff heart. Can you speak to that?
Sure. Basically, a stiff heart simply says that there's a lot of fibrosis. And so it's not as efficient as it should be. The heart is still functioning, obviously. You're up and around, you're doing things, but it does say that there's a lot of fibrosis, and perhaps thinking about if there's inflammation in the rest of your body, using an anti-inflammatory or an immunosuppressive, not a steroid, would be something to try to do to prevent further stiffening of the heart. Basically, a stiff heart is a heart with a lot of fibrosis.
Thank you, Dr. Furst. I'm a diffuse scleroderma patient with a heart murmur, fairly normal echo, and a couple of incidents of, what is this, syncope? How do you say that?
Syncope, passing out.
Thank you. Although I wasn't dizzy when either of these episodes happened, one of which happened during infusion of Flolan for Raynaud's. EKG shows RBBB. Am I starting with a general cardiologist to investigate, or starting with a scleroderma cardiologist?
I'm not sure I actually like these questions because they're individual patients. I'd rather talk about general issues, but I think that in general, when there's a fair amount of cardiac involvement, you should be working with both a rheumatologist and a cardiologist. You should see the cardiologist because they have some of the approaches that we use, for coronary artery disease and stuff. They're very familiar with those. They're very comfortable with those. They can help you with that, but they should not go off on their own without consulting the rheumatologist. So this is one of those things which in so many cases we all know are true. We need a team of people working.
Right, because at the end of the day, Dr. Furst, we talk about having doctors that specialize in scleroderma. So we always talk about a rheumatologist and a rheumatologist that specializes in scleroderma. Is that the same for cardiology? A cardiologist that specializes or has a specialty or special interest in cardiology? Well,
the cardiologist, that's their thing. It's their heart. They think of the body as a heart. And oh, by the way, there's a body attached. So their expertise in the heart is really quite important, so long as it is part of the body. So that's why you need a team.
Thank you. My Raynaud's has gotten considerably worse. Does that mean I need to push for MRI? I have only had heart echo.
Great question. So remember, we talked about the fact that it appears that you can get Raynaud's of the heart. And people who have a lot of Raynaud's, for example, people who have digital ulcers, things of that sort, they probably have Raynaud's in other tissues as well. I've learned a lot as I've begun to be more aware of what's going on in the heart. So I would recommend getting a cardiac nuclear magnetic scan to see where you are. I certainly am using it more frequently than I used to. even though, as we know, only 10 to 15% of patients who have heart fibrosis have any symptoms. Bottom line, answer is yes.
Thank you. How important is it for my family to learn CPR, and is there a difference from corticosteroids and prednisone?
Oh, good questions. Okay. I think that everybody learning to do some CPR is very important. The implication is that I think that a patient with scleroderma is more likely to have to require CPR and suddenly pass out and be in danger of dying. Remember what I said, only 1 to 1.2% of patients who have scleroderma die of heart disease. Patients who have arrhythmias or have congestive heart failure have a higher probability of getting in trouble. I think in general, patients' families should be aware of problems and, learn about things like that. But they should also learn about things like supporting patients with scleroderma through depression or helping them with physical therapy. It's part of the very large job that comes with being a family member of a patient who has scleroderma.
Thank you. Is it possible to have cardiac Raynaud's without visible Raynaud's changes in the hands? And she also said, thank you, Dr. Furst.
Oh, by the way, I'm sorry, I forgot. Corticosteroids are the general term for anti-inflammatory steroids. So prednisone, prednisolone, methylprednisolone, a lot of drugs like that. But from the American point of view, corticosteroids generally are prednisone. So now let's go on to this other question. I lost it. What was it?
Sure, I'll reread it. Is it possible to have cardiac Raynaud's without visible Raynaud changes in the hands?
Great question. Answer is we have absolutely no idea.
Okay.
I think we can leave it at that. That's a great study that ought to be done, don't you think?
Yes.
But it's a good one.
Hey, if you had the answer, you'd give it. So appreciate it. This is just a comment and I like it. So it says, love you so much, Dr. Furst. Because of you, I am smarter than my doctors. Thank you for taking your precious time to educate our population. Scleroderma sucks, but because of you, it sucks a lot less.
Thank you very much. That was very nice.
Yeah, I couldn't resist. Next question is atorvastatin. Am I saying that?
Say Lipitor, much
Yeah.
easier.
Okay, and Lipitor the same?
Yes.
Okay, so is maybe one of them a generic?
Yes, Lipitor is a trade name. Atorvastatin is the generic name. Now, I think there's room for a discussion here. We talk about statins as all being the same. It's not quite true. For example, rosuvastatin has been shown to be associated with fewer cardiac deaths than atorvastatin. Do we know that it applies to scleroderma? No. For the moment, atorvastatin is the only thing about which we have data, but one could hope that other forms of statins can also be effective. This is important because some people can't tolerate one statin, but might be able to tolerate another.
Thank you. Appreciate that. I got it. This is one that was sent to me, and he says, since Dr. Furst is discussing the heart, I have a question that is cardiovascular in nature, but it may or may not be off target, and he'll let you decide. Since strokes are cardiovascular events, are scleroderma patients at a higher risk for strokes? And then the same question regarding MCI, mild cognitive impairment, or dementia. If so, what can we do to mitigate the risks?
God, that's a fantastic question. We are only beginning to understand that large vessel disease occurs in scleroderma, and the large vessel disease that is part of scleroderma may associate with strokes. we actually don't have clear data, but my anticipation is that just like in the heart, where there's microvascular damage, you can have microvascular damage in the brain in scleroderma. The good news is there's absolutely no data that the potential effects in the brain affect brain function. So that, for example, dementia is much more likely, as far as we know, to be due to non-scleroderma causes than is scleroderma. So that mild cognitive impairment, as far as we know, is not due to the scleroderma. We don't have all the answers again. We've got some great people asking great questions, but that's where we are today.
And is there anything that a scleroderma patient should do to, like you said, mitigate this from happening?
So, you know, dementia is a big problem. It scares all of us.
Yes.
And, you know, what is known to people are developing drugs for dementia, and they aren't there yet, but they will come. When they come, they should be applied to patients with scleroderma or any other mild cognitive impairment. Meanwhile, the things we can do are use the brain like a muscle. There's no question that when you use the brain, for example, crosswords, Scrabble, causing the brain to really function actually develops other pathways for thinking, and consequently is something you can do to mitigate mild cognitive impairment. For the moment, if you have it, get into a study of mild cognitive impairment.
Great, thank you for that. I'm in heart failure and I've been taking almost all of the medications listed. I've been on prednisone for almost 2 years now, but my doctors are trying to wean me off. Should I continue a low dose? I notice more pressure and chest pain when my dose is lowered.
Prednisone is a drug that I love to hate. It is one of the nastier drugs existent. As far as the data exists today, the use of prednisone for heart disease per se is unlikely to be useful at the very lowest doses. If it's being used for something else, then that has to be addressed. As a general rule, getting people off prednisone is very important. As a general rule, if someone is having symptoms as they come off, then you have to slow down the tapering. As a general rule, you have to look at what's causing that chest pressure. For example, it could be GI problems. It could be muscle problems. It could be arthritis, and you treat those to allow the prednisone to be further decreased. Using prednisone for 2 years really brings up a tremendous number of issues, and we all know them, and we all hate the drug. Sometimes you have to use them. In your situation, I would urge you to try and figure out what's going on, and then try to treat that so you can get off the prednisone.
Thank you, Dr. Furst. This is another one that was emailed. I have been having PACs, pre-atrial contractions, and have been told that at my age, they are all right. I wonder if PACs are related to scleroderma. I have no pain and I am just distracted by them. I can learn to live with them. Appreciate your thoughts.
Okay, so PACs, particularly in young women, and I don't know how old or what gender this person is, but particularly in young women, are quite common. And if not in runs of it, called supraventricular tachycardia, they really are of no importance. What I would do in your case is I'd get a Holter monitor or a Zeo patch or something like that. I'd get an echo. All those, if those two are okay, I'd ignore it if I could.
Thank you. If you have Raynaud's, does that mean that includes Raynaud's of the heart, or is that a separate heart issue?
So as we talked before, Raynaud's of the heart is associated with external Raynaud's, does not always happen just because one has external Raynaud's, and does not happen, as far as we know, independent of external Raynaud's. So the answer to that question is that if you have a lot of Raynaud's, you might have cardiac Raynaud's. The answer to treating that is, first of all, to do a nuclear magnetic MRI scan to see if there's fibrosis or any other problem, and maybe do a arrhythmia test like a Holter monitor or a Zeo patch.
Thank you. This is another very nice comment. You are the best, Dr. Furst. I've gained so much knowledge over the years being with you. This session has provided me with so much knowledge about cardiac involvement in scleroderma. Please continue to provide us with knowledge through these super informative sessions. Thank you.
Oh, that's so nice. Thank you, whoever you are. I appreciate it. I really do.
Sorry, guys. Please bear with me. Is CellCept effective in preventing further fibrosis in the heart? Many of us take it to protect the lungs. Is it also effective with the heart?
So as I mentioned, we really don't have many studies for it, but on principle, it makes sense to use an anti-inflammatory and immunosuppressive for the heart just as much as it is for something else. So I would definitely think that that's a real possibility, that it can prevent further damage to the heart. You know, we're just starting the era of examining this closely. But for now, the answer is yes, continue to use it for the heart as well.
Thank you, Dr. Furst. If annual echoes are normal, is it necessary to have a cardiologist on your team and an annual visit, or only see a cardiologist if there are problems?
Okay, so that's actually a complicated question. Annual echoes are clearly indicated, particularly early on in the disease. If someone has a long-standing stable disease, it is not necessary every year. If your rheumatologist is well-versed in what the echo means and what it portends, then you don't need to see a cardiologist all the time. What I would recommend is a basic first visit, and then an occasional visit if symptoms require.
Thank you. Does having Raynaud's for a long time increase the chance of Raynaud's in the heart and the severity?
Great question. If you look at Raynaud's of the fingers, long-term Raynaud's results in endothelial hyperplasia. The inner lining of the heart kind of doubles and triples. If that also occurs in the myocardium, then having long-term Raynaud's would be associated with more possibility of scleroderma heart disease. Is that proven? Absolutely not. What would I do? If you haven't had one, get a cardiac MRI.
Thank you. A few comments. Thank you very much, Dr. Furst. So very helpful and interesting. Another one that says, thank you for this great talk. I now have numerous questions for my scleroderma clinician team. Hold on a second.
That's nice. I'm sorry you're getting, your voice is giving out on us there.
That's okay. I'll keep going, raspy or not. I'm trying to, there's a few in here that aren't related to today's talk, and I apologize, but I'm not going to be reading those questions because we're sticking with specific questions due to heart-related symptoms and scleroderma. So I apologize if I don't read your message, your question out loud. I don't know, this is sort of one that kind of is, kind of isn't. I have poor circulation in my fingers and toes, and it's hard to get my oxygen level. Why are there so many medical personnel that don't know this, i.e. the ER or as a hospital patient? Good question.
So when you go to get a 6-minute walk test or anything of that sort, it is critical that you get a forehead oximeter, which looks at the oxygen level in the forehead. That done on the fingers, the ears, are totally inaccurate. I've had people call me and say, I don't understand why this patient's alive. Her oxygen level is 0. Well, that's because they did it on the fingers and the patient had Raynaud's. So the answer is that if you're going to do an oximeter, do it on the forehead or don't bother. And I don't know why people don't get it, but there you go.
Thank you. And that's a good one, because I remember when we worked together and we would do like the 6-minute walks, we always used the forehead because you couldn't get the right reading on the fingers.
Exactly.
Thank you. Thank you, Dr. Furst, for an interesting presentation. After experiencing 3 vasovagal episodes, the 4th episode resulted in a complete blockage between the upper and lower heart. This resulted in an implant of the micro pacemaker 2 years ago. On the plus side, doing extremely well.
So remember what we talked about, an implantable cardiac defibrillator? That's what was needed for this patient. I'm glad she got it. It's one of the well-known and actually known to be effective treatments.
Thank you. Not a question. I just want to thank Dr. Furst for his time, and yet again, a very informative talk. Nice to know that some of my current meds might be doing double duty for me. I don't hear much about azathioprine. I was actually thinking the same thing about azathioprine.
Right.
I know you guys still used it.
Azathioprine was tested, 20, 30 years ago, and didn't show to be very effective. The lung doctors love azathioprine and use it a lot. And this study was done with azathioprine. It is a generalized immunosuppressive, slightly different mechanism of action than mycophenolate, but generally covering many different cells in the immune system, tends to be not very well tolerated in scleroderma because it upsets the stomach so much. And that's part of the reason it's not used very much, but it is available and can be used if needed.
Thank you. Did I already ask this question, or maybe I'm seeing it twice? Is CellCept effective in preventing further fibrosis in the heart? Many of us take it to protect the lungs. Is it also effective with the heart?
Yeah, this is kind of a repeat.
Okay.
We don't know that it is, but it might be, and certainly we hope it is.
Okay. This is more, I think, of a comment that my doctor has me on CellCept 2,000 milligrams a day and methotrexate 15 a week, but it does give me stomach problems and loss of appetite.
So that's a clinical pharmacology type question. Using the two together has not been shown to be effective, but particularly with patients in a lot of joint disease, methotrexate is likely to be more effective than mycophenolate. Upset stomach is one of the most common problems, and treating the stomach very aggressively with different medications, it's a different talk, is appropriate. Switching to subcutaneous methotrexate might be a way around some of that.
Good to know. Thank you. I'm done with questions, and I have a couple just more thank yous. Thank you for your knowledge and time, Dr. Furst, and thank you, Dr. Furst. We've got a little bit of time. If there's any more questions, I'll ask Dr. Furst, and if not, we'll probably just end the meeting a little early. If anybody else wants to type a comment to Dr. Furst, you're more than welcome. Oh, I just found one more, 2 more. Thank you so much for the information about Raynaud's of the heart. Where can I find more information about it? Based on your descriptions today, I think this is causing my heart issues, and I'd like to learn more and pass this on to my care team.
Well, you know, this Raynaud's of the heart is actually a relatively new issue. The prominence of the heart in scleroderma in itself is only being brought to the fore more recently. We just recently did a combined consensus statement about how to define heart disease in scleroderma. And when you think about Raynaud's, as you saw, it's not easy to see. And we don't know enough about it. I think that having vasospastic angina is something that the cardiologists are familiar with. They look at it from the coronary artery point of view, but from the microvascular point of view, it can also be quite obvious. And I would actually ask your cardiologist about treatment for the vasospastic angina and see what they have to say. There are, by the way, some more invasive treatments that are used to increase the blood flow to the microvessels that had been used more frequently. And I actually don't know what the most recent studies about its effectiveness is. But the point is that vasospastic angina is a known entity and can be treated, and you should talk to your cardiologist about it.
Thank you. Thank you very much for sharing your knowledge and insight with us. Would you be able to discuss pulmonary hypertension at another session?
Sure. I enjoy doing it. It's one of the things that are important for scleroderma patients. So the answer is yes.
Thank you very much. This question I can answer. Is there ways to see your previous talks? Diane, we have a library of talks, and any talk that we've done with Dr. Furst, we have recorded, and we have it on our library on our website. And we also have a YouTube, which when I do a recap of this meeting and send you guys the recording, I'll send you that information. And also even the National Scleroderma Foundation has like an archive also. And there could be talks that we haven't covered, but we have covered a lot with Dr. Furst. Pain in scleroderma, lung involvement in scleroderma. We've done, updates on clinical research. We did the COVID talks, but definitely there are ways to see his previous talks. And if you have anything to add, Dr. Furst.
Yeah, I do. I think the Scleroderma Foundation of California has set out specifically to give patients a library of places they can go to get these kind of talks. And so I urge you all to think about it and get involved with helping us move our knowledge forward.
Thank you, Dr. Furst. Many more kind comments. Excellent presentation. Thank you. Thank you very much, Dr. Furst. It's always wonderful to learn. Another question, should scleroderma patients be especially concerned with cholesterol control?
Good question. When you think about cholesterol in any disease, one of the issues is that the types of cholesterol in inflammatory diseases, immune diseases like scleroderma, is not doing the job it's supposed to. The anti-inflammatory aspects of cholesterol simply aren't able to do the job in the face of the inflammation. When you treat the inflammation, what may happen is the cholesterol may go up, but the bad cholesterol goes down, and some of the aspects of the cholesterol that are negative disappear. And so if someone has an hypercholesterolemia, particularly if the LDL is up or the peroxidase is up, then treating the cholesterol per se can be helpful in the inflammation of the underlying autoimmune disease, including scleroderma, of course.
Thank you, Dr. Furst. More thank yous. Thank you, Dr. Furst. I have more info now to bring attention to my cardiologist. Thank you so much, Dr. Furst. I learned so much today. This is more of a lung question, and I'm going to let you make the decision, Dr. Furst. I was put on CellCept due to my lung report with some fibrosis. How bad does the fibrosis have to be put on CellCept? No one can tell me.
Okay. The data with respect to mycophenolate and scleroderma is actually pretty good. We've done a study which compared cyclophosphamide to mycophenolate for the lung. And the data are that if a person starts with some abnormality in the lung, and it needn't be much, if, for example, the FVC is less than 80%, that's just one of the pulmonary function tests. In that study, using mycophenolate stabilized the lung compared to the control. So if you're extrapolating data, then in this study, anybody who has an FVC less than 80% will benefit from mycophenolate. And that may be the answer that this person needs.
Thank you. And can I add, you should be able to tell your doctors that you want an explanation of why they decided at this point to put you on it. That's your right as a patient to understand that. And obviously they saw something to do it. So you should ask them to break that down to you. I just wanted to add that.
You know, most, not all, unfortunately, but most rheumatologists actually enjoy good questions from their patients. And so when you ask a good question like that, then most of the time you're going to get a good answer. So don't be afraid to ask the questions.
Well said. Thank you. This one says, thank you for asking my first question, answering. I am very symptomatic with hypoxia, dyspnea, palpitations. Lungs are clear. Though MRI is clear and biopsy positive, what other tests can help me? Okay. I think this is the one who had the positive endomyocardial biopsy, correct? I believe so.
Yeah. So in this case, I think using a functional test might be very useful. I would suggest something like a cardiopulmonary exercise test, CPET. I also would recommend a Zeo patch to see if you have recurrent arrhythmias that are causing you difficulties. So I think those two, a CPET and a Zeo patch, would be a good place to start. And I don't know how long ago you had the HRCT and the pulmonary function test, but if it's been more than a year or two, then let's put it differently, more than a year, given your symptoms, they should be repeated.
Thank you, Dr. Furst. Another thank you so much. I don't know if this, Kelly, if this is really part of this or not. I'm not sure. Maybe it's because of what he said about ablation. It says, what are your medical thoughts on doing a procedure called endovenous ablation to my right leg? I don't know if that has anything to do with this or not.
It's really a different question. It depends on what's the cause, how bad it is, what level it is, etc., before you decide to do that. And I can't answer that at this point.
Okay, thank you. She also said, thank you, doctor. You're terrific to assist you. I love you. Let's see. Hold on. I'm trying to get my arrow to go down a little bit more here. Good question. Would it help to donate our bodies when we die?
Good. It's an excellent question. I think in general, that depends on where. If you go to a large and good center, then that can help understand scleroderma and therefore advance it so other patients can do better. If it's in a place where there is not expertise and good pathology, then I don't think it is worth the tremendous contribution you're trying to make.
I love the way you explain that. Thank you. Thank you, Dr. Furst, for your time and knowledge. Another thank you, Dr. Furst, and thank you for your time. May God bless you always. And many of them are people that I've recently met or known for a while, and it's just so nice to see your face. I mean, not your faces, your names up to date. And I want you to know we're so happy you're here today. Let's see. My cardiologist wants me to take enalapril malate. Am I saying that right?
Yep, malate. That's fine.
but reading the pamphlet having scleroderma is a no-no. What does Dr. Furst think?
Okay. Enalapril is called an ACE inhibitor. And when there is particularly an early disease or rapidly advancing disease, then using an ACE inhibitor may prevent the ability to discover if a person is getting kidney disease. So in that situation, using an ACE inhibitor may prevent allowing us to treat you in the best possible way. If you've had the disease for a long time and it's been difficult to control the disease and your kidneys are doing well, then using an ACE inhibitor may be one of the better ways to get control. So it really depends on you as an individual, as is usually the case.
Thank you. You have more thank yous. And somebody anonymous, thank you for all you do, Tina. Thank you for whoever said that. That made me smile. And this isn't really, I guess it kind of is, because it's related to fatigue, which could be related to heart-related issues. So I'm going to read it and I'll let you decide, Dr. Furst. I have had diffuse scleroderma for 25 years and I'm doing well, but fatigue is one of my main symptoms. Can you discuss fatigue and how to handle it and what causes it?
I think talking about fatigue is a wonderful possibility, but I think it needs to be done in a team approach. I think we should have, for example, someone like myself who's a rheumatologist, as well as a psychologist, as well as a behavioralist. And I think sort of a panel approach to something like fatigue could be very interesting.
Thank you. Going back to donating your body, I really need to know what would be the area, the scleroderma patients in the state of California. Like, is there a specific place? Do you know, Dr. Furst?
Well, yeah, yes and no. I think that UCLA, University of California in San Francisco, UCI, San Diego State. But you'll notice that they're mostly the academic centers, and the large academic centers, particularly who have some scleroderma knowledge or scleroderma centers, would be quite useful. Another one, although I'm not so sure to what degree the pathologists there are into it, but Cedars-Sinai in LA is developing a good scleroderma program, so maybe that's a place. But right now, most of the larger university would be the best place to go.
Thank you very much. I think that's it. That's all the questions that I have.
Okay, well, great. And thank you all for listening. And it's been a pleasure, and I love your questions. Take care.
Thank you very much, Dr. Furst. We appreciate you always. Thank you for your time today. And so glad that we didn't lose our internet while we did this. So everybody, thank you for participating. Dr. Furst, thank you again for being here today. We wish everybody a wonderful rest of your day. Thank you again.
Bye-bye.
Thanks, Dr. Furst.
Bye.